Welcome to the deep dive.
Hi there.
Today, we're doing a deep dive specifically for you endoscopy techs and nurses. We're pulling the most crucial practical knowledge from a really great source, Dr. G.S. Raju's video on the small intestine.
It's a fantastic resource.
Yeah, and we even use Google NoteBookLM to help us structure this chat and, pull out the key points that really matter for your day-to-day work.
Exactly. Our mission today is pretty simple. Let's unpack the vital anatomy, what you actually see during a scope, the critical biopsy techniques, and the common problems you might run into in the small intestine.
All tailored for your role in the unit.
Precisely.
Okay.
Let's start with the basic layout. The small intestine is, well, it's essentially one long tube.
Okay.
Starts right after the stomach and winds its way down to the colon.
And it's the part you're navigating.
Yes,
You've got those three main sections, right?
exactly. First up, you have the duodenum. Shortest part.
How short?
Only about 20 to 30 centimeters long, and it has that distinctive C shape.
Okay, C-shape. Got it.
Then comes the jejunum. That one's much longer, maybe around 2 meters.
2 meters.
And finally, the ileum. That's the longest section, roughly 3 meters.
3. Okay.
And that connects to the colon through the ileocecal valve.
Now, that C-shaped duodenum, that seems really important. The source breaks it down even further, doesn't it, into smaller segments?
Absolutely. And knowing these is key because the landmarks change as you advance the scope. You have 4 portions.
4 parts of just the duodenum.
That's right. D1, that's the duodenal bulb right after the stomach.
Okay.
D2, the descending duodenum.
Descending.
D3 is the transverse portion.
Across.
And D4, the ascending duodenum, which then leads into the jejunum.
Okay, D1, D2, D3, D4.
What's really fascinating and honestly a bit critical from a procedural standpoint is how that C-shaped D2 section wraps tightly around the pancreas.
Ah, right.
The source points out that a lot of things are happening in this area. It lists structures like the bile duct, the pancreatic head, the uncinate process.
So crowded.
Very crowded. The superior mesenteric vein and artery, even the aortas are close by. This isn't just anatomy trivia. It really emphasizes why precise scope handling in D2 is so critical.
Yeah, you're navigating a really packed space.
Exactly. Packed with vital structures.
That really puts the need for precision into perspective. So thinking about why patients end up needing this procedure, beyond the structure, what's the main job of the small intestine that leads to the symptoms you see?
Good question. It's absolutely vital for 2 main things. It continues digestion, sure, after the pancreas does its work.
Okay.
But most importantly, it's where almost all the absorption of nutrients from your digested food happens.
The absorption is key.
It's the key. So if that process goes wrong,
And you see symptoms,
right, the classic ones you'll see listed are diarrhea and malabsorption.
which then leads to weight loss pretty quickly.
Often, yes. Unintended weight loss.
So when you're prepping a patient and they come in with that cluster diarrhea, malabsorption signs, weight loss, exploring the duodenum with the scope is probably a key step to figure out what's going on.
That's often the case, yeah.
Hmm.
Let's talk about what that exploration looks like from your viewpoint, assisting with the scope.
Okay.
Once the scope is guided through the stomach, past the pyloric ring,
Okay.
you enter the first part, D1, the duodenal bulb.
Right, the bulb. And visually, what's the first cue? What are you looking for? Maybe not looking for.
Well, the source describes the bulb as featureless.
Featureless.
Yeah, and that's a crucial visual cue.
Yeah.
It means there are typically no folds in D1. It should look relatively smooth inside.
Okay, so D1 is smooth, no folds. How do you know you've successfully moved on into D2, the descending part?
As you advance the scope from that smooth D1 into D2, you immediately start seeing these prominent circular folds. The presence of those circular folds is your visual confirmation. Tells you you've made the turn from D1 into D2.
That's a clear landmark then.
Definitely. And then, when trying to get further, maybe into D3 or D4, sometimes just withdrawing the scope a tiny bit can help reduce any loop. A loop in the stomach or D1. Exactly. And that often allows the scope to just naturally advance forward. Other times, a gentle push might be needed to get around that D2 bend and reach D3 and D4.
Right. Now, a really critical part of the job is assisting with biopsies, especially here. Why is taking samples from the duodenum so important? What did the source highlight?
Biopsies here are absolutely essential, especially in patients with symptoms like dyspepsia, diarrhea, malabsorption.
To find the cause.
Precisely. The big one we're often ruling out is celiac disease, but there are other causes of malabsorption too.
And technique matters.
Very much so. The source gives specific guidance for the descending and distal duodenum, so D2, D3, D4. You should aim for at least 4 to 6 biopsies.
4 to 6. Okay.
And it's best practice to take them one at a time. Ensures they're captured properly, not lost, easy to label.
Makes sense. And there was that very specific detail about the bulb D1, the smooth part?
Yes, and this detail is vital for diagnostic yield, especially for celiac. The source specifies taking biopsies from the duodenal bulb, D1,
Where exactly?
between the 900 and 12.00 positions relative to the scope's view.
9 and 12 o'clock.
Yeah. That area seems to give the highest chance of catching the early microscopic changes of celiac disease if they happen to be present just in the bulb.
That's incredibly specific. So once you've got those samples, they go off to pathology. What is the pathologist actually looking for under the microscope?
They're examining the lining, specifically the villi,
Villi.
these tiny finger-like projections that line the small intestine. Normally, they should be nice and tall, slender, look like, well, fingers on a microscopic level.
Okay.
But in conditions like celiac disease or other gluten sensitivities, those villi change dramatically. They can become stunted, kind of blunted or flattened. Sometimes they even atrophy, completely, basically wear away.
Wow.
And the pathologist also looks for an increase in inflammatory cells, specifically lymphocytes, within that lining.
So flat villi and more inflammation.
That combination, villus atrophy and increased lymphocytes, is the histological hallmark for diagnosing celiac disease from a biopsy.
Got it.
Although, it's important, and the source notes this, other conditions can sometimes cause similar changes too.
But those changes directly explain the malabsorption, right? Losing the villi.
Exactly. When you lose those villi, you lose that huge surface area needed for absorbing nutrients.
Like trying to soak up water with a flat board instead of a sponge.
That's a great analogy. Nutrients just can't get absorbed effectively.
I
They
agree with
pass
you.
right through.
Which leads back to the diarrhea and weight loss.
Precisely. And severe untreated malabsorption isn't just, inconvenient tummy troubles. It leads to malnutrition and all the serious health problems that come with it.
Okay. Let's shift gears slightly. What about other things you might see during the scope? The source showed some examples of common issues, right?
Yes, definitely. Beyond seeing just a normal bulb, you might identify an ulcer there, a duodenal bulb ulcer. The source showed a picture of what that looks like.
Okay, ulcers. What else?
Sometimes you might spot a nodule. Often looks like it's just under the surface, a submucosal nodule.
And what are those usually?
Most commonly, they turn out to be benign carcinoid tumors. Very rarely, they could be something malignant, but usually carcinoid.
Good to know. And moving further down into D2 and beyond.
Well, you could certainly find polyps or adenomas, similar to what you see in the colon.
Makes sense.
And in patients with certain genetic conditions like
Okay.
FAP, familial adenomatous polyposis, you might see lots of adenomas scattered throughout.
Right.
And something else, particularly in patients with liver disease, like cirrhosis, portal vein thrombosis.
Yeah.
You can actually see varices in the duodenum.
Like esophageal varices, but lower down.
Exactly the same idea. Dilated blood vessels. The source also mentioned seeing related things like general red markings or distinct cherry red spots on the lining in those patients.
Interesting. Okay, so let's try and tie this all together. What does this all mean for you, the tech or nurse assisting? We've covered the anatomy.
The function, why absorption matters.
What D1 versus D2 looks like through the scope.
The critical biopsy spots, like that 9 to 12 zone.
And some common pathologies you might encounter.
Right. Understanding these details, knowing D1 should be featureless, seeing those folds appear in D2, knowing why getting 4 to 6 biopsies or hitting that specific spot in the bulb is so important.
Or recognizing an ulcer versus a nodule, or those varices.
It's all incredibly valuable. It directly impacts your ability to effectively assist, ensure quality samples are obtained, and ultimately contribute to getting the right diagnosis for the patient.
This deep dive really does highlight that connection, doesn't it, between sometimes subtle visual things or getting a tiny tissue sample just right, and the huge impact on a patient's overall health, their nutrition, everything.
Absolutely. And think about this for a second. When you're really focused, maybe it's a tricky scope, but you're making sure to get those 4 to 6 biopsies from D2. Or you're carefully positioning to help get that 9 to 12 o'clock sample from the bulb.
Yeah.
You're not just, following orders. You are playing a direct, crucial role in potentially diagnosing something like celiac disease, a diagnosis that can change someone's life and which could be missed if the samples aren't adequate.
That really puts the importance of technical precision into perspective.
Doesn't it, Jet? It makes your role incredibly meaningful.
Definitely something to consider as you continue your crucial work. Thanks for joining us for this deep dive.
My pleasure.